Hi everyone, and welcome back. This session is aimed at discussing the anatomy and the physiology of labour, and hopefully by the end of the session you'll have a better understanding of how your body works through the process. What I want to reiterate is that I am going to be talking about spontaneous labour, so that's when you go into labour naturally by yourself. This is not induction of labour, as induction of labour involves a slightly different process. And what I want to make clear is that, and hopefully it will give people a lot more confidence about the birthing process, is that labour is a very natural physiological process that every woman is designed to go through. And please try and sort of think about this process as the same process that every mammal has to go through when they're giving birth to live young, and the process is very, very similar with human women as well. And also be reassured that women have been going through this process since the beginning of time, if you like, and if this process didn't work effectively, then the human race would not have evolved as it has done today. So what is labour? So basically labour is a process that the body has to go through to soften and thin the cervix, which is the opening to the womb, then dilate it open enough so the baby can pass through the birth canal and able to be born and come into the world. So I just want to show you this picture here, and this gives you an idea of what the work that the cervix has to do during the first stage of labour. So on the right hand side, you can see a cross section of the uterus with a full-term baby in it, with this long kind of structure here. That is a cervix before it's done any work at all. So it's completely long, it's firm, it's closed, and the baby's high up in the uterus. If you look to the left hand picture here, you can see that there's a lot more muscle at the top of the uterus, because all of that cervix down the bottom has been pulled up and dilated open, and the baby is now much lower in the pelvis, ready to be born. To demonstrate that in a bit more detail, I've got a picture here to show you of the cervix, which is the opening to the uterus, which is demonstrated here before you go into labour. So that it's nice and thick, it's firm, it's long, and it's holding the baby in. By the end of the first stage of labour, your cervix will have got to the point where you can see here, hopefully, it's completely thin and it's soft, and it's just starting to dilate open. You can see the gap there, and there's the comparison of both, so that hopefully you can see the difference. So labour is classed in 3 different stages, as demonstrated here on the slide. We've got the first stage of labour, which is the cervix doing all the work of softening, thinning and opening, and that is split into different phases. We've got the latent phase, the active phase, and then the transitional phase, and I'll go through those different phases as we go through this session. We've then got the second stage of labour. That's at the point where the cervix is fully open and the baby then can be pushed out into the world. And then we've got the third stage of labour, which is after the birth of the baby to the point of the placenta and all the afterbirth being born. So, before we talk about the phases in more detail, let's talk about the hormones that are needed for this process to work effectively. And it's really important to understand, if these hormones cannot work effectively in natural labour, spontaneous labour, then the whole process can be delayed. So we have got oxytocin. Now oxytocin is released from the inner part of your brain. It's released from the non-thinking part of your brain, and that's called the hypothalamus. As human beings, we have developed over evolutionary time a thinking brain. If you think about other mammals when they're going into labour, they don't really think about this process, they just do it. It just happens, it's something that happens to them, and the hormones are released from the certain parts of the brain which allow the process to take place. So oxytocin is released and your uterus is covered in oxytocin receptors, and then the oxytocin receptors pick up those the oxytocin from your bloodstream, and then you start to have what we call contractions. So that's when the uterus starts to feel very tight, and you start to feel lots of kind of like period type cramps, and that will build up gradually as the labour progresses. The next hormone that I want to talk to you about are endorphins. Now, endorphins are released again from the brain, and they are really important in aiding you to achieve some form of natural pain relief. Again, what you've got to remember is that up until about 100, 150 years ago, we didn't have pharmacological forms of pain relief for women, so they relied solely on the natural process and the release of endorphins to be able to gain some form of relief from the discomfort of the contractions. And again, taking it back to how mammals work, this is exactly what they do as well. What tends to happen is that the brain releases a pulse of oxytocin into your blood. You have a contraction. The contraction lasts for a certain amount of time, it goes away, and then you get a release of endorphins. The further along your labour goes, the more oxytocin is released, and then the more endorphins that are released, because the more oxytocin that is released, the stronger the contractions become, therefore the more your brain knows you need endorphins to help you aid with pain relief. Endorphins will take you into a very euphoric kind of zone in labour. So normally women who are in natural labour, who are relaxed and in an environment that they are comfortable in, will not become more vocal, but actually become much more quieter in themselves as the labour progresses. They will want to go in on themselves. They often feel very kind of like an out-of-body experience, and that's the job of the endorphins, and that's what they are there to do. We've got a third hormone which is called adrenaline. Now, adrenaline is what gives us that instinctive fight or flight kind of feeling, and it's something that we don't really want much of in labour, because if we get too much adrenaline release in labour, that can increase your anxiety levels. And if your anxiety levels are increased, that blocks off the endorphins. So what then can happen is we end up in a vicious cycle of you feeling more anxious because of the adrenaline, and that fear kind of kicks in. The endorphins are blocked off, so you're feeling much more discomfort with the contractions. And because you're feeling much more discomfort with the contractions, the adrenaline rises even more, therefore the endorphins are blocked off even more, and the pain that you're feeling increases. So then we can end up in a vicious cycle of where interventions in labour might be needed. So the first stage of labour then is separated into two phases. So we've got the latent phase, or early labour as you might hear it called, and then the active phase, which is the established labour. So during the early phase of labour, unless you've been otherwise advised by your care professionals, we do recommend that you stay at home for as long as is possible. And what is happening during this phase is that your body is slowly starting to release those crucial endorphins and oxytocin to start to get your cervix to soften and thin. Women during the latent phase of labour will experience a little bit of discomfort, normally at the front, down the lower part of their pelvis, and sometimes round in their lower back as well. You will still be aware of what's going on around you. You will still be able to, have conversations and want to talk. And what's really important is that you are mobile and upright during this phase. Eventually, as your cervix does become fully thinned out and soft, as I've demonstrated in this picture here, you will start to find that things change a little bit. What then happens is that your body goes into what we call the established phase of labour. Now, what that means is that the cervix has done all the softening and thinning out, and what it has to do now is start to dilate open around your baby's head. For this to happen, you now need much stronger contractions that last much longer. So there will be a change in the pattern of your contractions. They'll become much more regular, they'll last much longer, and by this point, hopefully, your endorphins have really increased. So women that are in established labour tend to, in between their contractions, not want to talk to anyone. They tend to go very quiet, very in on themselves, and this is a very natural state to go into when you're in labour, and much easier to get into this state when you're at home. You can hopefully see on this picture here that I've got that there's this lady here who is clearly in the early phase of labour, so she's noticing her contractions but not too phased by them, and then compare it to this lady here who's clearly deeply in on herself and in a euphoric state of mind. So for women, when they start to enter this kind of state and they are contracting much more regularly and much more strongly, that might be a time when you might want to start thinking about calling a midwife for support. Positioning in labour, so it's really important to be upright and be mobile. The reason for this is because the baby has to do lots of different manoeuvres inside the womb as well in order to get themselves into the right position so that they can be born. Just to demonstrate this, when a woman is upright and mobile in labour, her pelvis is able to be at its maximum capacity to enable the head or the baby's head to engage fully. Now, particularly when you're expecting your first baby, before you go into labour, the baby's head is probably quite nicely deep in your pelvis. The way the human pelvis works is that the inlet of the pelvis, the widest part, is from side to side. So for the baby to fit into the pelvis, it needs to go in a sideways motion. However, the outlet of the pelvis isn't widest from side to side, it's widest from top to bottom. So the baby has to be able to rotate itself during the process of labour to get itself into the optimal position to give birth. So that all has to happen inside slowly with the contractions. The more you contract, the further open your cervix becomes, the further down your baby's head will be able to go. As the baby reaches the deepest part of your pelvis, it's then got plenty of room to slowly rotate its head so that its face then faces your spine. It will then tuck its chin deeply onto its chest so that then by the time you get to the end part of labour, so when your cervix is almost fully dilated, the smallest part of the head is able to exit the pelvis. For this process to work, being upright and being mobile is essential. And here, hopefully, I can demonstrate no matter where you give birth, whether it be in a hospital setting or in a home setting or in a midwife-led unit setting, that there are ways and means of maintaining these positions. The worst possible position for any woman to labour and give birth in is on her back. Again, I will demonstrate this using the pelvis. When a woman is upright or she's in a kneeling position, her pelvis is in this position. This part here, the sacrum, all the ligaments go really soft during late pregnancy and then in labour again, even softer. And what we do find is that this part of the pelvis kind of detaches itself a little bit and it comes out. So a woman in the later stages of labour, we often notice she's got a bump on the bottom of her back. And that's because this part of the pelvis has done its job to pull itself out, and that gives the baby even more room to go through the pelvis. So a woman being in an upright position or kneeling, as she would instinctively want to be during labour, and as she will try to be during labour, will be in this position so that the baby can do its job using the aid of gravity to be able to move downwards and rotate in the fashion as I described earlier. Now let's look at the pelvis if a woman is on her back. So there you can see instantly that you've got a mattress or a hard surface there that is slowing the process down for the pelvis to be able to open up fully, for the cervix to be able to open up fully, and for the baby to descend deep into the pelvis, because it can't go downwards, it's trying to go sideways. So hopefully that will enable you to understand why it's important that a woman is not on her back, but she's actually upright and mobile and in a forwards or kneeling position. There will come a time during the last part of the first stage of labour where we hit something called transition. Now, transition is where we get a shift in the hormones. So as I explained earlier, through the majority of labour, you need oxytocin and you need lots of endorphins. you don't need much adrenaline. But there comes a point in the last part of labour, normally when your cervix is getting to almost fully dilated. This picture would show here, this cervix is probably about sort of 8 centimetres dilated. There's a shift in hormones because now your body knows that you need to wake up out of that euphoric zone, because it won't be long before you have to start pushing the baby out. So you will get a shot of adrenaline. And what this does is it can make you feel very panicky, it can make you much more vocal, it can make you feel really frightened. And that's where it's really important that all your care providers and your birthing partners that are around you are able to give you the support that you need to be able to get you through this phase. And this phase can last anywhere from sort of 20 minutes up to an hour. Everybody's very different. Some women during the transitional phase really do feel a sense of a loss of control. Others will just feel a little bit more kind of unsettled in themselves. So the severity of it can depend individually as well. But what I do want to say is, particularly for birth partners, when you do see this phase happening, don't panic. Be reassured that it's a normal part of the physiology of labour, and it will come to an end. So once the transitional phase has occurred, that's then where the cervix will become fully dilated. So there's no more cervix around the baby's head. So what you will now feel is the baby is really, really low. And this picture just demonstrates that here. What you can see here is a bulge of waters, which will break at some point, and we'll talk about that in another session. But you'll feel the head really, really low in the pelvis. Very much a lot of pressure in your back passage as well. And to demonstrate on the pelvis and the doll, by this point hopefully the baby's head has got its chin tucked on its chest and it's really, really low down. Because it's so low, you feel more pressure in your back passage because it's squeezing everything. Now, the second stage of labour is sectioned into 2 phases. We've got the latent phase again, and then the active phase. The latent phase normally is where we get a bit of a break in contractions. As I've already said, you feel lots of pressure, but you're starting to feel the beginnings of these very strange urges to bear down with the contractions. So no more is the cervix pulling is the uterus pulling the cervix up. Now what we've got is all of that muscle that was down around the baby's head is now up here, and it's a really strong structure now at the top, so that the contractions can now become what we call expulsive. So every time now you contract, the top of the uterus pushes down hard onto the baby's bottom, which will push the head down lower into your pelvis, and it gives you that urge to bear down. You will want to be in all sorts of different positions during this phase, because what you're instinctively trying to do is to get your baby to get into exactly the right position so that it can be born. Eventually, you will go into the active phase, and that's where the contractions will start to come back. They'll start to become more regular again, and that urge to push becomes just about unbearable, and your uterus will start to, with the contractions, push the baby through the birth canal. With first time mums, this phase takes longer than it does with second time or subsequent babies, because the body's never had to stretch the birth canal in this capacity before. So with first time mums, we do expect it to take a bit longer. What you do have to do though is follow your body's instinct. Again, birthing positions, you're going to want to be upright, you're going to want to be in a squatting, kneeling, forward facing position. The last place you're going to want to do is be on your back. So I want you to be aware that you need to follow those instincts that you're feeling. Those urges to push as well, you need to follow your body with those urges, and what will happen is the baby will move backwards and forwards and backwards and forwards in the birth canal, and it might be a while before we start to see any part of the top of the baby's head. Eventually what will happen is that the muscles will stretch enough and the baby will come low enough so that we can start to see the top of the head, and then the baby goes back again. And we want this to happen. This is meant to happen. This is physiological. At this stage of the game, the placenta is providing the baby with as much oxygen as it can in between your contractions, and every time you bear down, the placenta gets squeezed a little bit. So it's important for the baby to have a release from that squeeze and be able to come back up again, so that it can recover itself and get lots of oxygen ready for the next contraction and push down into the pelvis. Ideally, we would let your body do this naturally, and we would not be encouraging directed pushing or breath holding, and that is where the caregiver gets the woman in labour to hold her breath and push hard and keep pushing and keep pushing and keep pushing. This is not something that is recommended, it's not something that is evidence-based, and it doesn't actually aid the birth to be any quicker. And in fact, what it can do is cause the baby to become distressed a lot more quickly because it runs out of oxygen a lot more quickly. If you think about how when you're pushing spontaneously or with your own instincts, you'll do that much more gently, and you'll give nudges rather than big breath holding pushes. So when the placenta is squeezed, it's squeezed for shorter amounts of time. If we're telling you to hold your breath and push down hard, it's having a big squeeze for longer, so therefore the baby's oxygen supplies are going to start to run out much quicker. Eventually the baby's head will come round and it will start to stretch your perineum. You will feel that stretch, it's quite an intense stretch, and the baby's head will stop going back. This is what we call crowning, and your midwife will now encourage you to just do lots of breathing or panting, so that when the rest of the head emerges, it slows that down as much as possible to try and reduce the amount of tearing that you might sustain during the birth of the head. After the baby's head is born, there will be a bit of a lull in contractions, okay? But baby's fine because it's still attached to its placenta and it's still getting oxygen via the cord. You will then get another contraction, which will now rotate the baby to the side, because now, if you think about it, inside the shoulders are the widest part. They've got to come out, but the widest part of the pelvis is from top to bottom. So with the next contraction, you will find that the baby will then turn itself to the side. Sometimes at the same time the baby will be born, but if it's not born with that contraction, it will be born with the next one, where the shoulders are released under the pelvis and then the baby is born. Baby should then be put skin to skin with mum immediately, and we'll discuss that in more detail in a different session. Here you can see on this slide women actually giving birth. I've just put this here because I think this is important to also see of a woman who is actually in that on her back position, being advised to hold her breath and push hard. This isn't something we would advise, and hopefully you can see in all the other pictures of women who are birthing in upright positions. And again, just to reiterate with the doll and pelvis why that would be. Your birth canal doesn't go in a straight line. There is curve to it. The baby actually has to come out in a curving way. And as I explained before, if you are on your back, when the baby's actually being pushed out, you're pushing them upwards, which is something that obviously is going to take longer and it's going to be more uncomfortable for you. If you are in that position where you are upright or in a kneeling forward position, the baby's actually now going to be able to come downwards, so it's going to make the whole process much easier for you. And this is the way that women are designed to give birth through evolution. So once the baby is born, what we need to understand is that the cord is still attached. And what I want to make clear is that it's really important, and it's in all of our guidelines, that we don't cut the cord too soon, because that's full of, in the placenta there's up to a third of baby's blood supply still in the placenta, which needs time to transfuse to the baby. So the cord, you can see here, this is a picture taken of the same cord at the time of birth, and then at minute intervals, 60-second intervals. And by 6 minutes, you can hopefully see it's white, it's empty, and the baby's been able to have its full blood transfusion. It would be at this point that we would recommend clamping and cutting the cord. We don't need to do it immediately. Also, you probably can't see it very well, but I've got pictures here of other mammals giving birth. When we look at nature and how nature does it, in most mammals, when they give birth, they don't stand immediately. They allow the newborn to have the full quota of blood from the placenta before they stand to sever the cord. So this is something that nature intends, and it should be happening, and it is in all of our guidelines. So then we hit the third stage of labour. So this is where the